Welcome, everybody. Welcome in the room, as well as virtual participants. My name is Aarti Shah, and I am from the Population Health Initiative. We welcome you here today at the Population Health Data Science Seminar that's hosted by the UW eScience Institute, as well as the Population Health Initiative. This series brings together thought-leading speakers and researchers from across campus to explore diverse applications of data science to pressing topics in population health. So before we begin, the University of Washington would like to acknowledge the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Suquamish, Tulalip, and Muckleshoot nations. Joining us today is Dr. Helen Chu, a physician scientist and an associate professor of medicine and epidemiology, as well as global health. She studies respiratory viruses and vaccines and has conducted several clinical trials of vaccines and therapeutics, including maternal influenza vaccine trial in Nepal, remdesivir for treatment of COVID-19, and efficacy studies of the Moderna mRNA vaccine. As part of the Seattle flu study, she developed a prototype pandemic preparedness platform where she developed strategies to conduct home-based testing for respiratory viruses to deliver antivirals directly to homes and to understand transmission of respiratory pathogens in families and young children and the sheltered homeless. This study first identified COVID-19 community transmission in the US. Dr. Chu is the site principal investigator for an NIH study of long COVID and the CDC funded study of SARS-CoV-2 population vaccine effectiveness study in children and adults. Early in the pandemic, she established a cohort of convalescent individuals with SARS-CoV-2, including the first US patient, and has followed this group for over 2 years to understand vaccine and infection-induced immunity, particularly against novel variants and the risk factors that predict long COVID. We will have time to following the presentation for questions. So if anybody has questions who is attending virtually, please enter them in the Q&A box on Zoom. And we'll make sure to repeat them as well, just in case anybody can't hear them. But at this moment in time, I'd love to invite Dr. Helen Chu to the floor to share a presentation on community-based approaches to understanding respiratory virus transmission. Welcome, Dr. Chu.
For that very kind introduction, I'm going to go ahead and get started. So, as Aarti told you, I study respiratory viruses and vaccines. And prior to the COVID-19 pandemic, my work was really on understanding maternal fetal immunity to vaccines that you give during pregnancy to protect infants, and then also in developing a platform for respiratory viral surveillance in the United States. And then, of course, COVID happened and everything changed. But what I'd like to actually do during this talk is talk a lot about the work that we did before COVID, because I think a lot of that, a lot of those studies have a lot of implications for how we manage COVID, and then also for the return of all of the other respiratory viruses, and then the new vaccines that are being developed for them. Okay, so here are my disclosures. So in this talk, I'll be going over the Seattle flu study, how it was developed as a prototype pandemic surveillance platform and how we transitioned this to COVID-19. Then go over how we have used the infrastructure of the Seattle flu study to develop something called the Husky coronavirus testing study, which is how we have tested students, faculty, and staff at the University of Washington. And finally, going over some of the results around the respiratory virus epidemiology studies that we've done in homeless shelters here in Seattle. So here we are in Seattle, Washington. It was 2018 when we were asked to put together some ideas for how we might develop a platform to understand how a pandemic might enter and spread throughout a city, and then develop potential interventions that could be used to stop the spread. So at the time, it had been 100 years since the 1918 flu pandemic. We knew that there was another pandemic that would be inevitable. We thought it was going to be flu. And that we knew that current surveillance strategies in the United States were really not well designed to detect novel pathogens. And what I mean by that is that a lot of the way that we collect data within hospitals and clinics is really very much not connected to each other. So we'll collect data when we see patients, it'll go to the electronic medical record, we'll collect their lab data, it'll go to the lab. There's really no way to take those two pieces of data and integrate them in real time. So we have a very fragmented system for which what is not really well suited to rapidly identify new pathogens as they arrive in a city. And so what we thought was to really try to develop this system where we take all of these different pieces that were very fragmented and bring them together. So the objective of the Seattle flu study was to develop a pandemic surveillance platform that could be used to identify new pathogens, develop strategies for rapid containment of spread before the months to years that it would take for a vaccine to be developed, eventually as a pandemic flu. So this was our strategy. We had really three pieces to it where we thought we could contribute. The first was to expand community surveillance. And the reason why we wanted to do that was because we hypothesized that a lot of the pathogens that could be coming in and leading to disease would not really come in through people who were hospitalized. It would really come through the healthy adults who were traveling and working and really spreading asymptomatically or asymptomatically in the environment. So we set up sites all around the city of Seattle for testing in places like public schools and workplaces and transit centers. And then we developed ways for people to be able to test themselves at home. And really to focus on the idea of having a rapid diagnosis. Because the idea with a rapid diagnosis is that once you know what you have, then you would take action to stop the spread. The other part of this is we wanted to build a high throughput lab, a lab that could identify multiple pathogens at the exact same time, to be able to do discovery for new pathogens. So for example, if a sample were to come in and we didn't know, we didn't find a pathogen at first pass, we could do sequencing for discovering of novel pathogens. And then also to use whole genome sequencing of the pathogens that we found to really be able to rapidly map chains of transmission. And for this to happen at really sort of a very much a much faster scale than what had been previously existing. And then finally, we wanted to build the system that would merge the clinical data and the laboratory data to take these two places where information was being housed and have them come together and speak to each other in a way where we would be able to have real-time access to those pieces to be able to make fast decisions. And we thought that by creating this system, this ability to merge those two pieces of data, we would be able to rapidly identify at-risk populations, understand how pathogens spread, and then critically take action to interrupt onward transmission. Here we go. Okay, so traditionally what we think of is that samples come in and data comes in through hospitals and clinics. When you're sick, you go to the hospital or the clinic, you tell someone you're sick, they take a swab of your nose, they get information about what kinds of symptoms you're having. However, what we thought was happening was that there was actually missing a large group of the population that was not coming in for care, or who were delaying their care until they were quite ill, sometimes days to weeks later after their symptoms started. And that really to find the first cases of illness in the community, we needed to go out into the community and look. So we went to places like schools and universities and daycares. We worked with the homeless shelters in Seattle. We set up testing sites here at the university, also in places like Costco and downtown at Columbia Center, at the light rail stations. And then critically, we also developed a way for people to be able to enroll online at home. So if they were sick, they would go to our website and enroll. And then we worked with partners, including groups at Kaiser Permanente, to also pull in the samples from their studies. And then we pulled in the samples from the hospitals because we thought that it was important for us to be able to prove this, that this community surveillance was going to yield this data faster than the clinic-based surveillance, so we had to have this comparator arm. The comparator arm was going to be the samples that came in from clinics and from hospitals. So we worked with the Hutch, we worked with University of Washington, Harborview, Seattle Children's, and then the Kaiser Permanente sites throughout the Puget Sound region. And then we work with all of these community sites, so Hutch Kids, which is a daycare that at the Fred Hutchinson, Costco, DESC, which is the Downtown Emergency Shelter, the University of Washington and different places around here, CTAC, St. Martin, which is also another shelter down in Soto. So lots of different places where we set up surveillance sites, and then we also captured the samples that were coming in from the clinical testing that was happening. And the way that we did this was by creating these kiosks. So we worked with a company called Formative. They helped us design these kiosks where they had 3 walls, and you would just come up to it and you would tell us whether or not you were having symptoms. And if you were having symptoms, any of these symptoms, and you showed these symptoms in the last week, you would be eligible to enroll. We would have you complete a questionnaire on an iPad, and then collect a swab from you. And then depending on where you are, you would get a different type of gift card for participation. So here at UW, we gave Amazon gift cards, and I think at the shelters we gave Target gift cards. But people would get gift cards for participation, and then they contribute their sample and their data. And the nice thing about this is that we actually had pretty good clinical data that went with this, the samples that were coming in. So people were telling us that they were having fever or cough or shortness of breath, which is actually very difficult data to get from a clinical chart. If you've ever tried to do medical record review, that information is actually not captured very well or very consistent. This is, I actually put this up here because it was one of the initial sites where we did surveillance until January 20th, when we were told that we weren't allowed to be there anymore. So this was a CTAC airport. We worked with Customs and Border Control, with CDC, with the Port of Seattle. We received security clearance to be at international arrivals. So what we did was we set up at the baggage claim in international arrivals, and we screened people as they were coming back from overseas trips. Strategically, what we wanted to do was really to capture the people who were coming in from Asia. So we had to be there at 7 a.m. in the morning to get the inbound Asia flights. We also did a lot of swabbing of surfaces at the international airport. So we put up filters to capture airborne viruses, and then we also swab places like the desk where people scan their passports before coming in. So we actually acquired quite a bit of data at CTAC. These are some of the places where we sampled. So one of the air samplers was, and then we had these kiosks which were at the international arrivals area. And it was interesting. You know, I would say that we learned a lot of lessons from doing this work at CTAC. It was an enormous amount of work to be able to get in there because of the levels of clearance we had to get. But I can see why this would be sort of an important place. We were able to find flu B, coronavirus, all sorts of things in the samples that we collected there. So this is actually what most of our spaces look like. So this was at King Street Station. We had our sign up. People would come up to us and they would tell us that they had symptoms, and then we would collect a swab from them. And then we also developed this platform where you could go online. So you would go to seattleflu.org. You would come into the website. You would basically do a self-consent and enrollment, and then you would enter your symptom data the same way that you would if you had come up to one of our kiosks. And then once you entered your symptom data, we would send you a swab kit. And this is the swab kit. Can you see that, or is there some sort of blue zip behind it? Okay, I'll just keep on going. So we developed this thing called the Quick Start Guide, where people would look at these instructions. We had this translated into 9 languages, and you would go through this and you would basically be instructed on how to self-collect a swab. And this was back in 2018, 2019, before the pandemic. And we found that this worked, that we were able to get thousands of people who would have the swab kit arrive at their house. They would be able to self-collect a swab and then get it back to us. And we had a 2-hour courier service either way. So it would go out within 2 hours and come back to us. And then we would test it in the lab. Once these samples all came in, either from the kiosks or the clinics or the home swabs, then they would all go to Leah Storita's lab at the Bronco Navy Institute. And that's just down the street, across the street right there. And there she developed a multiplex assay that tested for 26 different pathogens. And she would simultaneously test all of these samples. And this was done at very, very, very high throughput. So we would get through thousands of samples a day. looking for the presence of all of these different viruses, including flu, flu A, and the reason why we had that flu A primer on there. This is basically a list of all the different things that we look for. But flu A is what we thought would be the source of the next pandemic, that it would be an avian flu, an H5 or an H7, and that would not show up as a routine seasonal flu, but would come up as a positive on a flu A primer that would just pick up all influenza A. So then what we did was then we developed a way for people to have the results returned to them. So once that sample was tested, then you would go to the portal, and then within 24 to 48 hours, you would be able to log in, put in your date of birth. I don't know if any of you participate in Husky testing, but then you put in your date of birth, and then you have your result returned to you. And that was also, I think, at that point, fairly revolutionary, because very few research platforms were developed in a way where research results were returned to you, and you could take action based on those results. So those are sort of the things that we developed that first year, and these are some of the early data. This is courtesy of Mike Formulary, who used to be at IDM and is now at the Gates Foundation. And he created these maps of the Seattle area where he showed enrollments by neighborhood. You can see we had a lot of enrollments both down in South Seattle and then also in the university district, mostly college students there and homeless shelters down at the bottom. We also enrolled by in lots of other parts of the city. And then the other thing that we were able to do is to look at influenza by neighborhood. So this is again courtesy of Mike and Trevor Bedford, two of my collaborators for the Seattle Flu Study, where we looked at how quickly we started seeing flu positives over time. And the question was, if you have flu that enters into the city, does it enter and spread simultaneously across all regions of the city, or does it start in one place and then go out from there? And what we found with flu, as opposed to some of the other viruses that we also studied, was that indeed it just sort of arrived and explosively sort of took over the entire city, which I think we all know what happened in December of this past year. So in week 1 of 2019, week 1 would be CDC, week 1 is the first week of January. Compared to week 5, week 9, and week 13, you can see the spread of flu happening over the course of that period of time. The other thing that we did was then we took all of the samples that came in and then we sequenced them. So we performed whole genome sequencing. And the reason for that is because we really wanted to understand how viruses that enter a city would then spread from place to place, both within the city, and then how they would seed in from different regions and then go out to other parts of the world. And this is a phylogenetic tree, which I'm sure many of you are now familiar with. But basically, time is on the x-axis, and then those clusters represent closely related viruses. And this is developed by Trevor Bedford at the Fred Hutch using NextTrain. And these are some data from our very first year of the Seattle Flu Study, where you can see the sequences that came from Seattle represented, I think, the most sequences out of any city in the world that year, because we sequenced everything. So that red circle are, I think this word, oh no, wait, it's wrong. Okay, so that red circle over there are the Seattle samples, and you can see that there are samples that are coming into Seattle that are closely related to ones from Europe, from other countries in South America, from other parts of the United States. And that what we saw, if you zoom in on this, which I don't think I do in this one, but what happens is that you see different clusters of flu strains, flu H3N2 strains that were circulating in Seattle. And so then if you want to go ahead and visualize this, what you can do is see here, this is what we did where we took those samples and then we geolocated them. And then what we found was that the first flu positive was identified in a student at the University of Washington. It was most closely related to samples that had come from France. And then over time, there are some strains that sort of led to explosive growth in the population, and the other ones that extinguished very quickly. And so that was sort of the proof of concept of, well, you can actually use this type of platform to pull in samples from the community, pull in samples from the clinic, to test them for all of these different viruses, and then choose whole genome sequencing and map change transmission, even on a citywide scale. So the other thing that we developed that very first year of the Seattle Flu Study was an approach to test at home for flu, because we thought it would be really important to be able to develop a platform where people could test themselves for a pathogen, and then be able to use that result for decision making and potentially for treatment. So we partnered with two groups. One is called Allume, which is a company based in Australia that makes home flu tests. It's a research test that where the essentially it's an antigen-based test where you put the swab in your nose, you put it into this thing, this dropper receptacle, and then what happens is that it's a lateral flow assay, and as the test turns positive, it emits a fluorescent signal which Bluetooths to your phone. And then your phone will then within 15 minutes say flu positive, and then you get an email. So we took that and then we partnered with a telehealth company in Seattle. And then we used that result to be able to provide antivirals to people who were flu positive. And so this is how we did it. So we enrolled households virtually. We thought that it was important to develop a way to enroll people remotely without contact, because if you were in a pandemic, people probably don't want to come in and talk to a bunch of people. And then we developed a weekly remote text message platform for surveillance. And then when you were symptomatic and it had been within 48 hours and you had flu-like symptoms, we said, well, that would trigger a self-test with this home antigen test. And at the same time, we would also collect another swab that we sent to the lab and test by PCR for confirmation. So if your flu test turned positive on your home antigen test, then it triggered an alert to the telehealth group, 98.6, based here in Seattle. And then that telehealth group would then have an interaction with you to confirm that you're having these symptoms. And then they would send a prescription for a flu antiviral to the pharmacy. And then that home delivery of the antiviral would happen within a certain number of hours, and then you would take that drug. And then the idea was that could we develop this platform where you test at home, you treat at home, and then that way you have a completely contactless way of blocking transmission. So that worked. We published this last year and the year after, or the year before that. So we enrolled 185 households. We found 38 cases of lab confirmed flu that year. And then we found that people were able to use these home flu tests, that they were able to use them, that the sensitivity was not super, it was 69%, but that's actually not that much worse than, or better than COVID antigen tests. And the specificity was very good, it was 96%. And then critically, what we were also able to show is that once you had that result, you're able to take action on it. So of the people who qualified within that window, that 24 or 48-hour window, we were able to get antivirals to 16 of them, and that 81% of these occurred were within 3 hours of getting a prescription. So as soon as you were positive, you were contacted by your telehealth provider, they called in the prescription, and then that antiviral was arrived at your house within 3 hours, which is faster than most of the time when you go to clinic. And so we thought this is, proof of concept. It was very hard to do this study. It was a lot of sort of research coordinator time. This is a lot of Jessica Hyman, who's one of the research coordinators in my lab. It was a lot of her time to get this to work. But I think what it did show is that it's possible that you can test at home and you can treat at home, and that this is probably scalable, especially now that. But this was all before antigen tests and all before telehealth and all of that. But now that these things exist for COVID, this is probably a platform that should be used for COVID, home antigen testing, telehealth, and Paxlovid. I mean, this is probably what we should be doing. I think they do this in other countries. So we were, in a really good spot. We had a couple of successful things that we had done, developing this citywide pandemic surveillance platform for flu, and the home antigen testing and linkage to antivirals. And we were about to head into year 3 of Seattle flu study when, of course, at the time COVID-19 arrived. And then and so we were sort of really had to stop at that point with all of our flu work and pivot to COVID. But luckily, I think a lot of the work that we had done to develop that platform where we pulled in all the data from all these different places, we were able to do the sequencing in real time and then link that back with the metadata about the participants, allowed us to identify early COVID spread in the United States. So it's in many ways a real proof of concept of a pandemic surveillance platform can actually do those and actually can work. So that was good. We were happy with that when we were able to do that. And I think what we were able to show was that these samples that you collect from the community, if you're able to link them very quickly and you're able to do sequencing on them, they can give you really important early information that can guide public health decision making.
So this was just a publication that went along with that. We published a paper in a journal in eScience describing what we found using this community surveillance platform. And really the work done by Trevor was so important in this, where he developed these next strain figures, really showing the linkage between these early cases and then the very first cases that arrived in Washington State with the index case back in Snohomish County. Okay, so some lessons learned from those first 2 to 3 years. It takes a lot of time and effort to establish these trusted community relationships. But people were able and willing to self-collect samples for testing for flu. Novel surveillance strategies, including home-based sample collection, allowed for detection of flu and other respiratory viruses in the community. And then using the genomic analyses in partnership with the clinical data really allowed us to map these chains of transmission. And that really, I think as we think about this and what we need to do next, I mean, these contactless approaches are really going to be important to both diagnose and to treat. And then also the infrastructure that we built, that was, 2 years worth of work to build that infrastructure. It was a lot of work. And that kind of infrastructure needs to be in place before a pandemic rather than trying to be built during a pandemic for it to be effective. I mean, I think about some of the amount of work that it took us to just get into international arrivals at the airport and how many, hours of training we had about security, and that kind of work could never be done if you have if you're pressed on time, you don't have those pre-existing relationships. Okay, so now I wanted to pivot to the work that we've actually been doing for the last 1.5 years, 2 years now, which is really focused on the Husky testing program, which is what we do to test for SARS-CoV-2 here at the University of Washington. And then a lot of the work that we've done in the homeless shelters in Seattle, which I think has been really important and can serve as a model for how you diagnose and treat respiratory viruses in congregate settings like prisons, nursing homes, refugee camps, and then in shelters, of course. So we were contacted by the university to help with setting up a surveillance platform for respiratory viruses so that so the University of Washington could open safely back in fall of 2020. And so, and this was based on all of this information that was coming out about how college campuses were really the source of super spreader events. And these are just some of these snapshots that I pulled from the Seattle Times over that time period of showing, how Greek Row and the fraternity and sororities and Stone and the dorms and all of these places were really sort of the site of massive outbreaks of COVID-19 early in the pandemic. And so we decided to develop something called the Husky coronavirus testing study. And a lot of the work that we did to develop that was really based on the foundation of the Seattle flu study. A lot of the testing protocols, a lot of the data merging, that was made possible because we had already developed it for this pandemic platform. So here we are. This is how people enroll in the study. So you self-refer to a kiosk, like you do for Seattle flu study, or you sign up on the website and you have swabs sent to your house. You consent, you complete your questionnaire, and then you either self-collect a swab or in the presence of a research assistant, or you do it at home, not in the presence of a research assistant. And then those swabs again all come into the lab and they're all tested for SARS-CoV-2, and then we sequence all of them. So the first paper that came out of this was really sort of a genomic analysis of the 2020 outbreaks. And the question that we were asked by the university to answer was really around, are these outbreaks in the Greek community leading to spill over to the general population? And so, because what had been seen in some other populations was that when these college campuses were really the sites, the early signals of ongoing community spread, that what was happening on the college campuses would then spill over, and they would go to the nursing homes and then the hospitals and other places because college students interact with the general community. And so we wanted to try to answer this question for the university. So we went and we sequenced all of the samples that came in from all of these different outbreaks that were happening at the university at the time, and these were mostly in the Greek system. And then we also sequenced the samples that were coming in from non-Greek students, faculty and staff, and then also from King County in general, from all of our other surveillance platforms. And so what we found here, you can see is that, again, this is a phylogenetic tree, distance on the time is on the x-axis, and then the clustering indicates genetically related strains. And so what we found was that the Greek samples, which are in orange, tended to cluster with other UW Greek samples, and that the non-Greek and the faculty staff samples were more diverse. And so what that showed to us is that there were indeed outbreaks that were happening within these probably fraternities and sororities, and that these were separate from all of this different community circulation that was happening in the non-Greek population. One of the things that was really reassuring to us, and this is an early cut, but we have actually later data to show, is that once these events happen in the Greek community, they dead end. They did not then go on to lead to continued branching and seeding of the overall population as a whole. And that was reassuring to us that like whatever was happening in the Greek community was staying in the Greek community. It was not then leading to spill over to the general population. And one of the reasons we wanted to do this was to sort of decide whether or not we should continue this aggressive testing that we had developed. Or once you were positive, we started testing you every 3 days until the place where you lived was negative. And so we had done this with the Greek community, and they were really, really compliant with this, where once there was an outbreak identified in the Greek community, every single person in the Greek house would test every 3 days. And this allowed us to both find people very, very early before they were symptomatic and give them the diagnosis. And then also, I think because of that, because of this aggressive testing approach, allowed for truncation of these outbreaks and lack of spillover. So then the next time we had a fairly major event at the University of Washington was the Omicron outbreak, which I'm sure those of you who were here at the time remember that event that happened in January of 2022. And so this was this time period where students had come back, they were in person, and that and in the fall, and things were going well, and there just wasn't a lot of spread. There was an early Delta wave back in September of 2021, but that really sort of ended, and then we thought we were in good shape. And then Omicron happened, and then what happened was that we had this massive surge of cases in January of 2023 or 2022 at a time when much of the university was in lockdown, that there was continued after winter break, students were not back in classes in person. They were asked to stay virtual for several weeks while this outbreak was happening. And we learned a couple of lessons from this. The first is that we had the Delta wave, and that coincided with the start of school. We saw this very large Omicron wave that occurred despite movement to online classes and a community that was 99% vaccinated at the time. And then I think one of the things that you can probably conclude from this, and there are obviously lots of factors, is that transmission probably wasn't occurring in the classroom or in the workplace for that Omicron surge, and probably was likely a result of out of school events, social events, free brush, all of these things were probably contributing, because that, I don't know that move to online classes did anything to stop the spread of Omicron, that it was just such an infectious virus, and that probably there were events going on outside that could have contributed to ongoing spread of Omicron. We did have the opportunity with that, though, to really sort of compare those two outbreaks, the Delta outbreak, and then which is in blue here at the top, panel A, and then the bottom, which is the Omicron outbreak. And again, time is on the x-axis, and what you can see is that in the Delta outbreak, what's happening is that there are certainly these clusters, but the scale at which this Delta outbreak is happening is much, much longer, from September through December of 2021 compared to the Omicron outbreak, where basically just all of it happened simultaneously. Every single person got infected all at the exact same time. And what with Delta, we were able to do things like sort of discern these clusters that were happening in different groups. But Omicron was much, much more difficult because everybody was basically simultaneously infected with very similar strains. And that made it very difficult for us to identify chains of transmission. We did, however, have a chance to, and this is work I don't fully understand, but is led by Trevor Bedford, which is to work to understand how these introductions and the rate of growth has allowed us to be able to estimate in real time and basically an effective transmission replication number And the reason for that is because we have so much early data from when these students were first getting infected and from these massive testing events, that it allowed us to make some very, I think, very good predictions of how quickly Omicron would spread. Because what we found was that, for example, for Delta, the initial estimate for Delta was much lower compared to what we saw Omicron coming in at when it came in December of 2021. And this allowed us to be able to provide some guidance to the university about how to handle the winter quarter.
No, my phone. Okay.
So, the last part of my talk, I just wanted to go over some of the work that we did looking at the surge period. And so I don't know how many of you remember this, but we switched during the Omicron period from testing using these stations where somebody would sit there and they would watch you take a swab to basically a place where a bunch of kids were piled up and you took one and then you swabbed yourself and dropped it off, because we did not have enough people to be able to staff the number of stations needed to be able to test 1,500 samples a day. And so we developed this new system where people would self-collect. We had hypothesized that students would pick this up very quickly, but that faculty and staff would be a little bit slower and not be able to pick it up as quickly. And what we found actually pleasantly was that students, faculty, and staff were all able to do this type of unsupervised Dropbox approach to testing. And because we were able to demonstrate this during the Omicron surge, we've now fully transitioned to this approach. But this is basically a very cheap way to be able to do massive testing in an unmanned, unstaffed manner. And so this is sort of the data show this, that because of this Omicron surge and because there was no testing at the time almost anywhere else in Seattle, a lot of people ended up using the University of Washington, at least the faculty, staff, and students ended up using this as their primary mode of testing during the summer. And so what we found was that people, had there's a massive surge, and then and that what happened was that people were able to really adopt this use of Dropboxes in both the students here, and then down here in the faculty and staff, that even after this Omicron surge passed, we still saw that faculty and staff were able to use this as a way of testing, which we thought was great because it is much it's much cheaper and scalable for massive pandemic events. And then the last piece of the Husky testing study, which is new data that's been generated by one of the graduate students, is really around comparison of antigen tests against PCR tests. So if you remember, this past fall, we rolled out antigen testing as well, free antigen testing, university did. And so we had the opportunity among the 40,000 people that were enrolled in Husky testing to ask them about their antigen test usage and the results, and then to look at really concordance between the two. And here on the x-axis is time, so it's basically days from when the PCR test turned positive until the antigen test turned positive. And what we were able to show here is that that for people who had PCR results, that they were able to PCR test positive several days before their antigen test would turn positive. That having molecular testing gave you 2 extra days approximately of time of knowing your positive results before your antigen test would turn positive. And so that was helpful because I think it does allow you to be able to know earlier, especially in high risk congregate settings where you have the potential to spread. So, some summaries from the college campus testing. University-based surveillance allowed for rapid understanding of outbreaks in a highly vaccinated population. Repeated testing of individuals during surge events were essential to really capture these new infections, and that we were able to sequence these cases to show these explosive growth of these outbreaks, but then no evidence of spillover. And that Omicron really showed us that that you can have a massive wave with 99% of vaccination rates, maximum use of MPIs, closure of in-person activities, and still have everybody get infected with the exact same thing. So I think what I'll do, because we're coming on time, is maybe stop here and not cover the shelters, but I'm happy to go over that. And I think I'll just go ahead and skip through the shelter slides and show you some of and I'm happy to talk about this afterwards, but the big picture is there's a lot of virus shelters. everywhere. And that's is a place where it spreads very quickly. So I wanted to spend the last minute on this, which is the fact that now over the course of the last since 2018, so 2018 to now, so 5 years now, we've been doing citywide surveillance for respiratory viruses in Seattle as part of the Seattle flu study. And so at the beginning, if you remember, in 2018, we started surveillance. We found all of these different viruses circulating every single year with a dip in the summer. And then what happened is that you had the stay-home order where basically we saw complete interruption of the virus spread for just this period of time until July, August. But then interestingly, what we did was we saw that even though all of the other viruses didn't come back, rhinovirus did come back. We saw rhinovirus actually come back quite quickly. And then now, as we head into 2023, what you can see here on the right is that all of the viruses have indeed come back. So we had SARS-CoV-2, and now we also have the return, and you can just see very, very early here, the return of flu and RSV. And so over time, we've been able to really use Seattle, Washington as a, as Mike Formulary says, like an observatory of what happens at a citywide scale with large interventions that you introduce, like stay-home orders, masking, school reopening, workplace closures, and really observe its effect on all of these viruses that could be circulating and causing disease. So, so I wanted to just acknowledge all of the partners in our work. So we couldn't do this without Seattle. But there have been a lot of people who have allowed us into their spaces and to collect swabs well before this pandemic, made them understand why that was important. And then also all of the team, so that the investigators, there are over 100 of us in the Seattle city who contributed to all of this work, especially Leah Starita, who leads the lab, and then Trevor Bedford and Mike Formulary, who lead the analytic work, and then of course my lab at the UW, and I'm going to go ahead and stop here and take any questions.
The question coming from online. So it says, thank you for this incredible work. I'm curious about generalizability. Seattle King County is a HCOL area, and I assume higher SES, thus different behaviors, higher vax, etc. But the state, county, city had stricter COVID policies than a lot of other places. While I'm thrilled about this as a resident, does it cause challenges for these fantastic data to apply more widely?
Yeah, so the question is, should I repeat it?
I think online can hear because the room is mic'd.
Okay, so so the question is Seattle generalizable to the rest of the world because we vaccinate everybody and everyone is fairly highly educated here? Probably not. I think that there are things that we developed that probably cannot be transported over to other parts of the United States or the world. There are things that we can, though. And I think there's some very simple things that we've done that probably can be replicated and should be replicated. So for example, very simple things like saving clinical samples, and which is not what's happening in labs. So those samples usually get thrown away very quickly after testing. But if we were able to develop a way where samples are saved, that there's code written to pull in data from the electronic medical record, and that a lab is developed to do testing on these samples, that would yield a lot of information that we currently don't have. That just that link between the clinical data and the lab data doesn't exist in most places. And that's not a big lift. And I think a lot of these things are actually happening in other places now. And I certainly things that we've built, like 2-hour delivery to your house and this platform for seeing your results online, those things exist now because of COVID. People have developed them and they do work in lots of places. So I think that it is doable, but there's some basic things that have not yet been done, which I think would be really important for us to be able to respond to that. Any place that has labs and has an electronic medical record could probably implement.
Following up on that question, talking about different communities SES and how they interact with the rest of the community. What would be like the minimum populations for some of these strategies to work? Like, would you also implement them in more rural areas?
Yeah, it's a little bit harder in rural populations. We've talked about this a lot. I mean, I think that things have changed because of telehealth, and then also because of the ability to get people's swabs to their house. So that has really been, I think, a major change in how we deliver most care. And so I think that part makes it more possible, but the partnership that we have with public health, Seattle, King County, which is a very, good public health department. That type of partnership and the personnel that they have, that doesn't exist in a lot of rural places. I think that the strength of the public health surveillance system is probably what would make it hard to be able to do this type of work in partnership. But the actual logistics of what we do is not, I think, difficult to accomplish. So.
Are there questions in the room or from the virtual audience? Looks like Carol simply raised their hand. Carol, feel free to unmute and ask your question. Go ahead, Carol.
Unmute. Okay, that makes sense. I should have learned that at this point. Anyway, so trying to think as practically as possible as we think about rural areas or parts of urban areas that are not likely to be as trusting as maybe they are here. What kinds of things should we put in place before any of this happens? That's a hard, almost impossible question to answer, but you've got the infrastructure figured out pretty much.
Yes, I mean, I think there are a lot of things that it just takes longer to get things started in other places, but it doesn't mean it's not doable.
Yeah.
I think it's just a matter of spending the time upfront to lay the groundwork. I don't know that I really sort of see the homeless shelters as that different from a rural area. It was very hard to set up the infrastructure for a lot of the work in the shelters. But once it was set up, it proceeded just like everybody else. And then they were one of the first groups to ever have COVID testing because we were one of the first labs to ever offer it. So it helped them enormously to partner with us, but it just took a lot of time to set it up and to go to all the staff meetings and meet with everyone, answer all the questions and make sure that everybody was on board. So, but I don't know that I've found certain certain populations or groups more unable to do things. It just takes a little bit more time.
Right. Did you encounter any resistance of the sort that we see to vaccination and all sorts of other public health things?
Oh, yes, of course. And that's not specific to certain populations, it's just everywhere. I think it was just a matter of going back and asking more and more. And it helps to come from academia, I think. When you ask as an academic, people are more willing to partner with you on other projects. So, but we actually, I was surprised by how many people said yes to some of our ideas.
Thank you.
Stemming from the challenges, I'm curious to learn what challenges did you encounter shifting from focusing on influenza to COVID?
A lot of the challenges with COVID were sort of around the unknown nature of COVID. I mean, obviously early in the pandemic, which is no secret to anyone at this point, we were told to not test. So by several groups, and so we had to shut down our lab for a while. Because there was concern that we were a research lab doing testing that could, could generate false positive results. And they wanted us to prove that we were able to do these tests appropriately, and that we should be doing them in the first place because we were a research group. And so that took some time to work out. And so that was a big challenge up front, sort of overcoming those regulatory hurdles of testing. And then subsequent to that, I don't know that we've had a lot of difficulty with transitioning to more COVID work. What's one of the, a lot of it has to do with just not knowing about sort of the transmissibility of the virus and what precautions you have to take. So we very rapidly had to move to things self-collected swabs instead of having the research coordinators collect the swabs. So in the homeless shelters, we put out a lot more PPE, and people had to be trained on how to use PPE and all of those things. But that was just those were just the early days. So.
Thank you for sharing. I mean, I totally remember ordering a kit showing up at my house and doing the swabs. It was just so brilliant, I have to say.
Yeah, it was all the BBI logistics team. They developed that entire platform. I'm not a logistics person, but I learned. We actually had someone member from FEMA who had done work there, and the USAID, and a lot of these logistics team members, and they're the ones who developed this entire platform.
We have another online question, and just for the online audience, I'm also typing those into the chat. So if you're not able to hear, because somebody mentioned they were having trouble hearing, but the question is, and this is related a bit to a previous question, but can you speak to the political context of your initial work on COVID? How did it affect your work, if at all?
Yeah, so the questions around sort of the political context of the work around COVID early on. So when we first started developing the test for research use, we spoke to CDC and FDA and the different groups about being able to use it here in Seattle. And so one of the things that we had to discuss with them was, are we permitted as a research group to test? And then if we are permitted as a research group to test, we allowed to release the results to the participants. And so what we had initially been told was that we could test. Well, first we were told we could not test. And then several weeks later, we were told we could test. And so then we started testing, and that's when we found the first positives. And then after that, the question was around, well, can we release those results to the participants? And we were told not to, because we thought it was a research test result and should not be shared because it was not validated at the time. But there was no way to validate it at the time because there was no process. The process became possible 48 hours later after we had started the testing. So we went through that, but at that point there was no process. And so that was a time where we had to make a decision about whether or not to share the result with the participant, and we went ahead and did that. That was, a lot of what led to what was covered in the media. But ultimately, I think in the end, it was, we did the testing. We shared the data. It was helpful to people, but there was a lot of stuff going on. I'm happy to talk about it later.
All the infrastructure that you guys put in place, the kiosks and like connecting the clinical and the laboratories. Like you definitely showed a proof of concept and model for how we can like identify pandemics early on and take action. But considering you guys had to go all through these hoops as a research group, how do you envision in the future like that infrastructure being set up, like by like local governments, or like, I don't know, like what would be the ideal?
Yeah. So the question is around the logistics infrastructure and the kiosks and all of these different platforms that we put together, and the hurdles with research, and whether or not it should be done in an academic setting versus a public health setting. It should be done in a public health setting. I mean, the reason why we did it was not for us to be sort of the place where respiratory viruses were surveyed in a city. It was really to develop ideas and platforms that could be then handed over to others that needed it. And I think we have done that a lot. We share all of our protocols pretty openly, and all of our everything that we do is openly available. And so that's the goal, is that it becomes the work of public health. But as we know, public health is not well funded. They don't have the data infrastructure to handle a lot of this. But I can't really speak to Trevor, but I know that Trevor spends a lot of time working with Washington State Department of Health for these sequencing platforms to be built up, and that has been actually very, very successful.
You got to a little bit, but how have you seen Seattle like take up any of the stuff that you guys found yet, or?
Yes, so definitely, the CDC has now funded a lot of this type of work. And so a lot of the public health departments are engaged in this type of work now. Not so much the community surveillance, I would say, but certainly the laboratory and the genomics piece has been scaled, and I think is now squarely within Department of Health. So, and we have a grant with CDC that funds the BBI lab to do this in partnership with public health. So.
Speaking of scaling, I'm curious to learn if other organizations in other parts of the world have reached out to you to be able to do a very similar model as you are.
Yes, I think they have. We've talked to a lot of different groups about this, and generally our approach has just been, we have everything available on our Google Drive for anyone to use, and so whatever people want or need, they can have. Obviously, we had a large seed grant from Gates to enable all of this creation, and that many places don't have that. But it's costs much less than how much it costs to handle a pandemic. So. As if anybody wants protocols or data, we have it all, and it's on our website.
Questions from the audience? Hearing none, I just want to say thank you so much, Dr. Chu. This has been so informative on so many different levels, and we've been looking forward to having you share your knowledge and wisdom and your experience for a while now. So thank you for taking the time out of your day and being here for us and sharing your expertise.